Recording in progress.
The University of the Philippines, the only Philippine university to be named in the top 100 universities in Asia. This state-run institution is a paragon of education steeped in history and culture. The University of the Philippines system is composed of 8 universities around the country. The oldest of which is the University of the Philippines, Manila, the birthplace of the UP system in 1908 in Padre Faura, Ermita. Its oldest unit, the Philippine Medical School, later renamed to UP College of Medicine, opened in 1905, followed by the Philippine General Hospital in 1907. From the College of Medicine evolved other colleges and units that diversified the university's course offerings. In 1948, UP was transferred to Diliman, Quezon City, leaving behind some health colleges and the College of Arts and Sciences. In 1976, the School of Health Sciences was created in Leyte to offer a community-based, ladderized health education that aimed to help increase the availability of trained health workers in the province. 2 satellite campuses of the school were strategically set up in 2 other remote and underserved provinces, namely Baler Aurora and Coronadal, South Cotabato. The creation of the Health Sciences Center in 1977 brought together all the health units under one roof. The center was renamed to UP Manila in 1983. Today, UP Manila is the recognized pioneer and leader in health education, research, and public service in the Philippines. Among its pioneering programs are university-wide BS Nursing, Master of Arts in Nursing, PhD Nursing, Master of Health Professions Education, Integrated Arts and Medicine, degree programs in Public Health, MD PhD, MA Health Policy Studies, MS Health Informatics, MS Genetic Counseling, PhD in the Health Sciences by Research, and the only ladderized midwifery, nursing, and medicine degree program of the School of Health Sciences. UP Manila's credentials have led to its being the partner of choice of the World Health Organization, Department of Health, Department of Science and Technology, Commission on Higher Education, and other local and international groups to achieve health reforms. UP Manila is the only campus in the UP system that offers education, research, and training in a wide array of health disciplines and professions. The university offers courses in medicine, nursing, pharmacy, dentistry, Allied Health Sciences, Public Health, Health Professions Education, Community Health, and the Arts, natural and social sciences. The competency-based curriculum makes it stand out among the other schools. Since 2014, in compliance with the Philippine Qualifications Framework, the colleges are now transitioning to outcome-based education, or OBE. It enables the well-rounded development of students and unlocks their full potential as both health professionals and dedicated Filipinos. UP Manila educates the brightest students in the health professions and allied social science disciplines. Its students consistently top licensure examinations and assume positions of leadership and influence in government, the private sector, academe, non-government sector, and the community, giving them opportunities to shape national policies and programs on health. UP Manila is a pillar in the field of health research. UP Manila ensures that its faculty, staff, and students engage in research as a tool for health reforms to enhance education and complement its public service role. With the help of the National Institutes of Health, the center of and coordinating body for all researches in the university, UP Manila's researches have served as basis for national policy formulation and program planning. UP Manila's firsts in health research and policy include Republic Act 9288, the Newborn Screening Act of 2004, RA 9709, Universal Newborn Hearing Screening and Intervention Act of 2009, RA 10747, Rare Disease Act of the Philippines in 2016. Other advocacies include the studies on liver diseases that led to the mandatory vaccination of newborns against hepatitis B, commercialization of Lagunti and Sambong as proven effective medications for cough and colds based on the results of the National Integrated Research Program on Medicinal Plants, the Ventilator Project, and the Vision Screening Project for newborns and school children, all of these for healthcare improvement. Strengthening this role is its public service function rendered through the Philippine General Hospital, its community and volunteer programs, and scholarly and technical assistance to the government, private sector, and civil society. As the Philippines' biggest government and tertiary hospital, the PGH sees more than 500,000 patients a year from all over the country. It trains thousands of health students and health professionals from within and outside the university. Among its innovative programs are on child protection and poison control and management. Volunteerism is strong at UP Manila. From the very beginning, students are ingrained with their role as public servants. Through the Ugnayan ng Pahinuod, faculty, students, staff, and alumni volunteers provide health and sociocultural services that benefit depressed communities and indigent Filipinos. And to further reach out to the larger society, UP Manila offers the Community Health and Development Program and other community-oriented programs. This combination of excellent education, relevant research, and public service has produced thousands of exemplary doctors, nurses, dentists, pharmacists, public health experts, rehabilitation workers, paramedical workers, and more. With more than 100 years of excellent leadership in health, UP Manila is keeping itself nationally relevant and globally competitive by being at the forefront of Philippine health. The challenge may change, but UP Manila's response will be certain, excellent, relevant, and transformative.
Personally, HIV affected me from a personal level where I lost so many relatives to HIV when I was in high school.
I'm interested in how I can track and identify infectious disease outbreaks.
This summer, I got the opportunity to work on an adolescent HIV intervention in Cape Town, South Africa.
I wanted to dig deeper. I wanted to be actually part of the story.
Somebody had to do something, I wanted to make that change. I knew I have to do public health.
I was really interested in Brown because of their focus on learning public health by doing public health.
I like how there are many different research centers that allow different students to find what they're interested in, what they're passionate about.
One of the things that's different about Brown is we've got a lot of faculty and we don't have that many students. It's not that difficult to find a faculty member who's working in the area that corresponds to your interests.
So my first week here, my first class with Dr. Lurie, I asked him after class if I might be able to work with him, and he agreed. He's been helping me develop my research interest, and he's my thesis advisor now.
Brown was so open to allowing me to meld my work with my school experience. So it was going to make it possible for me to do both things at the same time.
What I love about Brown is the multidisciplinary, where it's not just one department. You can transfer and work with other members from other departments like epidemiology, biostatistics, health services.
I think there's several reasons that students choose to come to Brown. Of course, they love the idea of being able to design and to participate in the design of their own curriculum and their own experiences, learning by doing public health. And they have the whole university at Brown at their disposal to develop their skill sets and their knowledge base.
All of the professors are incredibly accessible, and a lot of them work in the field. So they're not just academics who have a conceptual understanding of public health, they're actually doing public health all the time. So they draw that experience into their lessons.
I think a central part of our philosophy is that students should be learning both in the classroom and in their hands-on experiences out in the real world.
And in the afternoons, I would get the opportunity to go out to local sites in the townships around Cape Town to see firsthand what all my learning in my classes was doing to have a positive impact on the people in Cape Town was something that was really fulfilling for me.
At Brown, we learn public health by doing public health.
I learn public health by doing public health.
I'm learning public health by doing public health.
We learn public health by doing public health.
I learn public health by doing public health.
HIV COVID.
Before we begin, please be reminded of the following house rules. Kindly mute your microphones, turn off your cameras, and you may use the chat panel to key in your questions. Thank you. Good afternoon, everyone. Welcome to the University of the Philippines, Manila, and Brown University's HIV and COVID-19 webinar series. We begin with the national anthem, followed by a short moment of silence.
Bayang mabiliw, pelas ng silanganan, alam ng puso, sa dibdib mo'y buhay. Lupang hinirang, tuyat ka ng magiting, sa manlulupi, di ka pasisingin, sa dagat at bundok, sa simoy at sa langit mong bukaw, may nilagang tula at awit sa paglayang minamahal, ang kisat ng matawat mo'y tagumpay na nagnidinig, ang bituin at araw niya kailan pa may di magdidinig, lupa ng araw ng walhati pagsinta, buhay ay langit sa piling mo, aming ligaya na pag may mga api, ang mamatay ng dahil sa'yo.
Our moderator for this session is Dr. Noel Huban, Professor in Basic and Clinical Epidemiology of the College of Medicine, University of the Philippines, Manila.
Good day, everyone, and I'm happy to be your moderator for today. Either it's good morning or good afternoon, wherever you are. I am Dr. Huban, as mentioned, and for the not included in what they said is I was also a Fogarty Fellow with this HIV program of Brown University. I was there in 1994, so I owe a lot to this program as well. For the opening, will be from our dear Chancellor, Dr. Carmencita D. Padilla. Dr. Padilla is a professor of pediatrics in the College of Medicine and currently the Chancellor of UP Manila. She's the founding director of the Institute of Human Genetics and Newborn Screening Center at the National Institutes of Health. Recognizing her varied contributions to the academic growth in genetics in the Philippines, she was conferred the Academician of the National Academy of Science and Technology in 2008. She's a pioneer in genetics in the Philippines and the Asia-Pacific region. In the Philippines, she is responsible for setting clinical genetic services at the Philippine General Hospital in 1990 and the various genetic laboratories now housed at the Institute of Human Genetics, National Institutes of Health. She is also responsible for setting up the National Newborn Screening Services in the Philippines, currently available to 7,400 plus health facilities in the country, being served by serving newborn screening laboratories and 14 continuity clinics that monitor the long-term care of the patient. In Asia and the Pacific region, she is a part of the pioneering group that established the Asia-Pacific Society of Human Genetics and served as president in 2008 to 2010. Dr. Padilla is a council member of the Human Genome Organization, an international organization of scientists from 69 countries around the world. In 2010, she was appointed the country representative to NAST, to the Inter-Academy Partnerships for Health, a global network of more than 150 academies in the world. Dr. Padilla has been the recipient of international and national awards. In 2019, she received the Robert Garthy Award, Most Outstanding Professional of the Year in Medicine, and the Eric C. Nubla Excellence Award from the Professional Regulations Commission in the country. She has more than 130 publications, and in the area of policy making, she is responsible for the Newborn Screening Act of 2004 and the Rare Disease Act and Republic Act 10747. Chancellor Carmencita Padilla is also the chair of the advisory board of the UP-Brown Fogarty Philippines. Let's all welcome Chancellor Menchit D. Padilla.
Vice Chancellor for Academic Affairs, Nina Simbulan, Dr. Don Operario, Professor of Public Health, Brown University, Dr. Rafi Deray, National Program Manager, Disease Prevention and Control Bureau, Department of Health, Dr. Rosario Taktakan Abrenica, Medical Specialist for HIV and AIDS Core Team Chairperson, Department of Health, Mr. Danvic Rosadino, Director, Operations and Research, Love Yourself Incorporated, Dr. Noel Huban, Professor of Basic and Clinical Epidemiology, UP Manila. The organizers of this webinar, namely Assistant Professors Maria Irene Quilantang, Ryan De Torres, and Dr. Calvin De Los Reyes, participants and guests representing different sectors and institutions here and in other countries, good afternoon. I welcome you all to this first of a 5-part webinar series on HIV and COVID-19 that is part of the University of the Philippines, Manila, Brown University collaboration through the NIH-Fogarty Training Program for the prevention of HIV in vulnerable populations. UP Manila and Brown University have a long history of partnership in preventing and managing HIV/AIDS among Filipinos that dates back to the late 1980s when Brown University assisted UP Manila in capacitating our researchers on HIV and AIDS. The collaboration yielded significant strides that led to the training of our faculty and research staff at Brown University under the US NIH AIDS International Training and Research Program, Fogarty International Center Fellowship Grants. The partnership also sponsored and funded several HIV/AIDS research colloquia and forums at the UP Manila, including the UP Manila Chancellor's Health Policy Forum on HIV/AIDS held in 2006, 2009, 2012, 2015, and 2018. In 2017, the collaboration was renewed, and this had witnessed and is still up to now conducting activities under the project UP Manila and Brown University Training Program in the prevention of HIV in vulnerable populations. A manifestation of this strong cooperation is this webinar series that commences today. After 3 decades, we are seeing a changed, more challenging landscape for education and training, research, and community service on HIV and AIDS. The Philippines is currently experiencing one of the fastest growing HIV epidemics in the world that started to be experienced in 2007 and went on for years. Unfortunately, health services in the country do not adequately meet the HIV prevention, testing, or treatment needs of the patients, especially the most vulnerable populations. While the World Health Organization has stated that people living with controlled HIV are at no greater risk for severe COVID-19 outcomes than persons without HIV, lockdowns and travel restrictions affect the patient's access to HIV clinics and treatments that jeopardize care and put them at higher risk for acquiring the coronavirus. Persons living with HIV that also have other underlying comorbidities are at a great disadvantage from the negative consequences of COVID-19. Thus, it is important during the current pandemic for these challenges and barriers to be addressed so that persons with HIV can maintain continuity of care as well as their social and mental support systems. Additionally, both institutions are taking the partnership to a higher level to raise greater awareness on the plight of people living with HIV during the pandemic through this webinar series. We are privileged to be joining forces once again with Brown University and grateful for the opportunity to address the immense challenges that the pandemic has brought upon HIV and AIDS patients. Today, and in the next 4 scheduled dates, your active participation and engagement in the discussion of the Philippine HIV pandemic response in terms of impact, challenges, and coping mechanisms is called upon for much needed wisdom, knowledge, experiences, and lessons. In behalf of our members, I thank Brown University for your trust and support to UP Manila in this alliance and towards our common goal of preventing and controlling HIV/AIDS among Filipinos within this pandemic and beyond. Maraming salamat po.
Thank you, Chancellor. The next speaker is Dr. Operario. He is a professor and former associate dean for academic affairs at Brown University School of Public Health in Rhode Island, USA. His research focuses on social psychological determinants of HIV, mental health, and related health issues. His NIH-funded projects examine public health issues among racial and ethnic minority populations, as well as sexual and gender minority populations in the United States, China, South Korea, Kenya, South Africa, and the Philippines. Dr. Operario is the current director of the Fogarty Global Health Training Program for the Prevention of HIV in Vulnerable Populations of Brown University and University of the Philippines, Manila. He also serves as the founder and the director of the Philippine Health Initiative for Research, Service, and Training at Brown University. At present, Dr. Operario mentors 8 NIH-Fogarty Fellows who are faculty members of UP Manila on their HIV-related research and community work. Let us all welcome Don Operario.
Good morning, good afternoon, and good evening to our global audience. And thank you all for participating in this webinar. My name is Don Operario, and I'm Professor of Public Health at Brown University. And I bring you warm greetings from Providence, Rhode Island, in the Northeast of the United States. As Chancellor Padilla stated, the Philippines has been experiencing one of the fastest growing HIV epidemics in the world. There are some estimates indicating that in the year 2021, 33 new HIV cases are diagnosed in the Philippines daily. Although HIV does not discriminate and all groups can be at risk for HIV, it tends to affect the country's most vulnerable communities. The Philippines national government and the nation's scientists, health providers, and community organizations have shown tremendous commitment to addressing this public health crisis. The COVID pandemic now brings another threat to all Filipinos. Each epidemic on its own is a serious public health crisis, but both epidemics together challenge our health systems and infrastructures, stretch our capacities to serve those in need, and require aggressive intervention and policy response. An effective response to these twin epidemics in the Philippines must be built on open communication, cross-sectoral dialogue, and collaboration. In this COVID HIV webinar series, we will hear from community members, first-line community-based providers, clinicians, scientists, and administrators. They will share with us the current state of knowledge, stories from the front lines, critical uncertainties and gaps in knowledge, and recommendations for policy and intervention to address the COVID and HIV twin epidemics in the Philippines. They will also be sharing with us, I hope, some signals of hope and a vision for a strong, resilient public health. COVID and HIV might be some of the defining public health crises of our lifetimes and of our generation. But our collective response to these epidemics will help to define public health for the next generations to come. I would like to thank Chancellor Padilla for her support of our institutional collaboration, as well as Vice Chancellor Pimentel and Professors Lofred Hernandez and Ray Imperial for their support of this program, as well as all of our participating panelists. And most importantly, I thank UP Manila faculty and Fogarty Fellows Irene Quintong, Calvin De Los Reyes, and Ryan De Torres for organizing every component of this program. Salamat and thank you.
Thank you, Don. Now for the webinar series. Webinar 1, this is what we have right now. The topic will be COVID-19 and the HIV Cascade of Care, Emergent Challenges and Innovative Response. For this one, healthcare agencies and institutions are confronted with several challenges to the delivery of HIV-related health services because of the COVID-19 pandemic. In this session, representatives from the Department of Health, healthcare institutions, and community-based organizations will describe the diverse and emergent issues related to HIV cascade of care brought about by the COVID-19 pandemic, as well as the strategies, innovations, and practices executed to address this concern. And for that, we have lined up speakers. For the first one, it will be Dr. Rafi A. Deray. His presentation is on HIV and COVID at the national level. Dr. Deray is a highly experienced in the field of public health. He was formerly the National Program Manager of the National Malaria Control and Elimination Program, a position he held from January 2016 to March 2021. He was formerly the Regional Coordinator of EPI and the National TB Program in the Department of Health, Center for Health and Development in Cagayan Valley. At the Department of Health Disease and Prevention Control Bureau, he is presently the National Program Manager of the National Rabies Prevention and the Control Program and the National AIDS and STI Prevention and Control Program. He finished secondary education at the Philippine Science High School and earned his Bachelor of Science in Zoology at the University of Santo Tomas in our country. He earned his Master's in Public Health, major in Epidemiology at the University of the Philippines, Manila, before returning to UST for his Doctor of Medicine. Everyone, Dr. Rafi A. Deray.
Good evening to all. The National HIV and STI Surveillance and Strategic Information routinely monitors the trend of the HIV epidemic in the country. Part of its mandate is to measure the trend of new HIV infections and determine the number of Filipinos living with HIV using a modeling exercise. The data-driven projections relies on population, behavior, and program data to accurately simulate the HIV transmission in the country. The following slides were designed to provide an insight on the impact of COVID-19 to the Philippine HIV response and its effect to the HIV projections. Before we start, let's talk about the different terms that will be used in this video presentation. We'll be differentiating the following: estimated people living with HIV or PLHIV, new infections, and cumulative diagnosed HIV cases. Estimated PLHIV or people living with HIV are the number of currently alive persons with HIV, regardless of the year they were diagnosed. These include those who were already tested and diagnosed, and those who were not yet tested for HIV and remain undiagnosed. Similar to PLHIV estimates, new infections are the pool of estimated, which include diagnosed and undiagnosed people newly infected with HIV on a yearly basis, and this represents the number of people being infected annually. Lastly, cumulative diagnosed cases are those cases reported on the HIV/AIDS Registry of the Philippines or HARP since 1984. This only represents the number of diagnosed people with HIV. COVID-19 situation has derailed the implementation of HIV program interventions in the country. Service provision was hampered by the closure of facilities, diversion of human resources, SHS, staff, peer educators, to COVID-19 activities along with social distancing measures, which restricted travel among key populations. From the analysis conducted by the Department of Health Epidemiological Bureau, National Prevention Program coverage decreased from 26 to 70%. with the national capital and region and Cebu City being heavily affected. Consequential to the decrease in preventive measures, condom usage among MSM and TGW slightly decreased from 38% to 36%. However, in the national capital region, where services and provision of prevention program among key population was severely disrupted due to the implementation of community quarantine, condom use decreased by 17% based on the online survey. The decrease noted was parallel to the decrease of the prevention program coverage for NCR. Supported by the 2018 Integrated HIV Behavior and Serologic Surveillance, or what you call IHBSS, MSM and TGW, who received the complete prevention package of HIV information, condom access, and HIV testing, were 6 times more likely to use condom compared to those who received neither one of the package. Meanwhile, comparison of surveys conducted by DOH-EB among MSM and TGW shows sustained sexual risk and behavior despite the restriction brought by COVID measures. Across the board, for the proportion of MSM and TGW who had anal sex in the past 12 months, the median number of months with anal sex, and the median number of anal sex partners. The impact of COVID-19 pandemic was a decrease in prevention coverage, decrease in condom use, at sustained high-risk behavior. This will result to higher HIV transmission and increase in new HIV infection. Due to service disruption brought by the effect of COVID-19 situation, it created a domino effect on the delivery and uptake of HIV services. On the number of reported HIV tests, it decreased by 61%. The number of newly diagnosed cases was reduced by 37%. And the number of newly enrolled clients to ART decreased by 28%. Looking at the bigger picture of the country's accomplishment to the 95-95-95 target, 68% were diagnosed from the estimated PLHIV, 61% of diagnosed PLHV were on life-saving antiretroviral therapy. Viral suppression among tested was high at 94%, but testing coverage is low at only 17%. Amid the country gaining ground with the Cascade, over 60,000 individuals remain to be vulnerable and were not on ARV. The impact of COVID-19 pandemic was a decrease in testing and diagnosis, decrease in treatment enrollment, ultimately resulting to an increase in treatment gap. This will result to higher HIV transmission, increase in new HIV infection, and higher AIDS-related deaths. Looking closer in the cascade of care by key population and vulnerable groups, the same treatment gap can be observed. Since the country's epidemic highly concentrated among MSM and TGW, the accomplishment in diagnosis and treatment is reflective of the investment and effort towards this key population. 1 in 2 MSM is in ARV. Meanwhile, there's a need for the country to give attention among other vulnerable groups such as PWID, other males, and women living with HIV. Only 1 in 4 lower risk males and women living with HIV are on treatment, while only 1 in 5 male PWID are currently on treatment. Furthermore, putting the PLHIV on treatment across KP and vulnerable group must be considered as one of the top priorities as service gap widens in this pillar of HIV cascade. Lower prevention coverage, lower case finding treatment coverage coupled with sustained behavior among key population was expected to increase the Philippine HIV estimate. Considering that the current COVID-19 has continuously affected our service delivery, there is a need for us to streamline innovative approaches to bridge the gap in HIV cascade. How did COVID-19 change our HIV epidemic. From 2019 to 2020, new HIV infections increased by 10%. However, due to the added burden of COVID-19, this rate doubled to 21% increase between 2020 and 2021. The young key population aged 15 to 24 years old remains to be the main driver of the new infections in 2021, contributing 40% of the new infections. There is a need to strengthen our HIV program among young KP or young key population through channels in which we'll be able to reach them, such as in school, online, and through the help of community-based organizations for young KP. Filipinos living with HIV will reach over 133,000 in 2021. This is the new estimate. With the current interventions and strategies, investments, this number is expected to triple by 2020. However, if we can successfully achieve the health sector plan for HIV, we will see a shift in the trend of HIV infection in the country. Our goal for the health sector plan 2020-22 is to reverse the trend of HIV epidemics by reducing the estimated annual new HIV infection to less than 7,000 cases. This is our current national projection scenario. Due to COVID-19, there was a 21% increase in the new infection between 2020 and 2021, and this count continued to increase until 2030. This projection assumes a slight increase in prevention coverage from 17% in 2020 to 19% by 2022. Meanwhile, treatment coverage is expected to slightly increase from 40% in 2020 to at least 50% by 2022. However, if we successfully reach 90% prevention coverage and 90% treatment coverage by 2022, we will effectively reverse the trend of new infection and will achieve the target of less than 7,000 new infections by 2023, a year delayed than the national target. But this will only be possible by accelerating prevention coverage from 70% to 90% and stepping up diagnosis, treatment, and adherence from 40% to 90%. This is quite a tall order. It requires the high-impact prevention, testing, treatment, and adherence strategies, and increase in investment to HIV service delivery and activities to promote an enabling environment. The impact of COVID-19 on the Philippine HIV epidemic are these. Amid the COVID-19 pandemic, there was a decrease in prevention coverage, while MSM and TGW has sustained high-risk behavior. Coupled with an increase in treatment gap, this doubled the rate of new infection from 10% between 2019 to 21% between 2020 and 21. Estimated HIV in 21 is 133,900, and it's expected to triple by 2030. Reversing the trend of new HIV infections is still possible as long as we achieve the health sector plan targets of 95, 95, 95, and 90% prevention coverage by 2022. However, the COVID impact will delay the achievement of less than 7,000 new infections by a year. Due to the COVID-19 pandemic, there are restrictions in the operations of HIV service facilities, which include limited operating days and time, repurposing of staff for COVID-19 services, staff needed to undergo self-quarantine or COVID treatment. 2, restrictions in client access to HIV services due to limited transportation and mobility due to quarantines. Outreach workers cannot conduct face-to-face interventions, and mass gathering for HIV prevention intervention not allowed or limited. Number 3, outreach key populations such as MSM and transgender people was limited due to closure of hangout sites, bars, and other venues where these services can be availed. School closures limit access to young key populations. With focused intervention diminished due to lockdowns, particularly in Cebu, and impact to supply chain for ARVs and commodities were delayed in the distribution. In response to the impact of COVID-19 on HIV program, in July 1, 2020, the Department of Health issued the Department Memorandum 2020-03-11, named Interim Guidelines on the Continuity of HIV and STI Services in the Midst of Varying Community Quarantine Systems. This document aims to provide guidance on HIV and STI program implementers on the transition to the new normal phase during the COVID-19 pandemic. Under Section 5, Specific Guidelines, HIV Services, the following adaptive mitigation activities were included or recommended. Number 1, collaborate with the existing network of community-based organizations in promoting the HIV and STI services of health facilities, including access to condom and lubricants, HPV screening and testing, and treatment. Ensure uninterrupted access to vital health services such as life-saving antiretroviral therapy to protect the health and safety of persons deprived of liberty with HIV who qualified for early release in prisons or jails. Promote HIV and STI services through social media applications, tri-media and visual channels, and newspapers. Support conduct of outreach activities by community health outreach workers, peer educators, and volunteers as long as they are provided appropriate PPE. Intensify facility-based HIV screening in rural health units and HIV facilities, such as social hygiene clinics, primary HIV care clinics, and HIV treatment hubs. Expand availability access to rapid HIV diagnosis algorithm, or RIVDA, especially in DOH regional hospitals, existing primary HIV care clinics, and social hygiene clinics of category A cities. Conduct close monitoring and reporting of ARV and other commodities based on timelines set in the Department Memorandum. Engage in telemedicine services with PLHIV and clients from the key population with new prejudice to quarterly physical pickup of ARV by PLHIV to ensure their health status is assessed, especially from the life-threatening conditions such as tuberculosis and HIV treatment failure. Provide electronic travel pass to PLHRV or community-based HIV screening provider or HIV case manager to facilitate the movement of individuals in case of localized lockdown due to resurgence of COVID-19. Ensure continuous access to ARVs, including the use of available courier services, hospitals or regional vehicles, and transport network vehicles or TNVS for pickup and delivery of ARVs, as well as engagement of partners from community-based organizations for ARV access points. Coordinate closely with HIV viral load testing centers for seamless referral of PLHIV for the scheduled viral load test. Collaborate with other government and private sectors to promote additional HIV prevention to key population, and care and support services to PLHIV must be exercised to enable them to cope with the prevailing situation and adjust to the new normal. In September 1, 2020, the Department of Health also issued a memorandum titled HIV Program Catch-up Plan, which further emphasized some key activities recommended by the national program to catch up with the program within the COVID-19 pandemic scenario. This includes advocacy and communication, under which we have boosting of social media accounts of social hygiene clinics and treatment hubs and available HIV services, virtual seminars on basic HIV 101, information on HIV testing and treatment services, online reach through social media application to connect to key population. On service delivery, ensuring availability of local vehicles to increase testing and treatment, ensuring the availability of drugs, the facility level by religious participation in the monthly NASPCP meeting, client-centered approach for delivery of ARVs and other HIV services, regular monitoring of use of reminder systems, and lobby for additional PPE to include trained members of key populations on community-based screening. In addition, the DOH issued on February 26, 2021, DM 2021-0116, or the interim guidelines on the identification and utilization of COVID-19 vaccination sites under implementing guidelines of site or non-health facility-based sites, such as schools, gymnasiums, and others that fulfill guidelines set in the National Vaccination Deployment Plan and subsequent guidelines may operate as vaccination site, provided that they are linked to a licensed health facility. During the May 12, 2021 PCCM regular meeting, one of the agreement was for the HIV program to develop a detailed HIV adaptive plan similar to the adaptive plans developed for TB and malaria program. This will be developed by the Department of Health in collaboration with the regions, key populations, with support from our international partners such as WHO and Global Fund through the PSFI. These are some of the key policies and interventions the department has issued to mitigate the impact of COVID on the HIV epidemic. One, on the programmatic side, shifting to online interventions for key population, including promotion of HIV and STI services through social media applications, tri-media and visual channels, including online outreach activities, expand availability and access to rapid HIV diagnosis algorithm, or RIBDA, especially in DOH regional hospitals, existing primary HIV care clinics and social hygiene clinics. Adoption of DSD, or the differentiated service delivery for HIV, conduct of program assessments related to COVID impact and regular data monitoring, as well as conduct of close monitoring and reporting of ARV and other commodities. So with that, I would like to end my presentation and thank you.
Okay, thank you. And for those who have questions for our speakers, please write it to the chat boxes, and then we will have an open forum after all three speakers have done their presentations. For the second presentation, it is HIV and COVID at the healthcare facility. The speaker is Dr. Rosario Jessica Cherry Taktakan Abrenica, and she's the head of the HIV department at the San Lazaro Hospital. It's one of the largest and the busiest state hospitals in the country. She's the chairperson of the HIV and AIDS core team of the Department of Health San Lazaro Hospital. She obtained her Doctor of Medicine degree at the University of Santo Tomas and the Masters of Public Health at the Institutes of Community and Family Health. She underwent training in infectious diseases and tropical medicine at the same hospital. She had clinical management for HIV infection and AIDS opportunistic infection training at the Osaka National Hospital and AIDS Clinical Center of Osaka, and has his fellowship in clinical management of HIV disease under the Arthur and Ashe Endowment at New York Presbyterian Hospital, Whale Medical College at Cornell University, New York. Let's all welcome Dr. Rosario Jessica Cherry Taktakan Abrenica. Welcome, Cherry.
Okay. Good day, everyone. I have been tasked to discuss with you about HIV and COVID-19 at the healthcare facility level. The objectives are the following: to present the challenges in the HIV care cascade at the hospital level during the COVID-19 pandemic, to present the strategies implemented by healthcare institutions to address challenges in the delivery of HIV care and prevention services during the pandemic. In the Philippines, these are the quarantine classifications, of which there are 4 main levels. The first one is the Enhanced Community Quarantine, or the ECQ, which is the strictest of these measures and is effectively a total lockdown. There's limitation on all forms of transportation, work suspension, alternative working arrangements, cancellation of mass gatherings, and closure of non-essential businesses. The next one is the Modified Enhanced Community Quarantine, or the MECQ, in which people will be allowed to leave their homes only to obtain essential goods and go to work in industries allowed to resume by the government. The next one is the General Community Quarantine, or the GCQ, which is generally less stringent than ECQ. Public transportation is allowed at a reduced capacity, and select businesses are allowed to operate at 50 to 100% of the regular capacity, depending on their industry. And the last one is the Modified General Community Quarantine, or the MGCQ, which is the most lenient. These are the challenges that we have noted: access to life-saving medications, treatment interruption, access to treatment without having to risk increased exposure to COVID-19 when accessing their medicines, and testing issues. This slide compares the HIV diagnosis and treatment before and during the COVID-19 pandemic. From January to December 2019, there were 12,778 newly diagnosed cases in comparison to January to December the following year, which went down to 8,058. For January to December 2019, enrollment to ARV accounts for 10,287, while the following year, it went down to 7,438. The source is from the HIV and AIDS ART Registry of the Philippines from December 2019 and December 2020. This can be explained by the total lockdown and border limitation, because patients can no longer go to the treatment facilities for testing issues and clinical care. Other health facilities, with the help of the peer support groups and partner NGOs, these are the strategies adopted in the new normal, in which there are differentiated outreach and testing strategies. One is online outreach, which is reaching out to the communities at the digital spaces. It can include education, risk reduction counseling, and provider-based referrals. Another one is social network testing, in which is the approach is to identify HIV positive patients and those who are at risk for HIV in their own social network. They identify, encourage, refer, and accompany them to HIV testing. There are still clients or patients who go to the hospitals to come for consult at the facility level. But wearing of masks and face shields is strictly enforced. They are screened for signs and symptoms of COVID-19 and also symptoms of opportunistic infection of AIDS. If found such, they are directed to the COVID triage, and then they will be given clearance prior to HIV OPD consultation. PhilHealth has issued an advisory number 2020-026, in which access to antiretroviral drugs and other services during the enhanced community quarantine. In the duration of the enhanced community quarantine being implemented in most parts of the country, the HIV treatment hubs and primary HIV care facilities must ensure that people living with HIV are enrolled in their facilities, are able to access the needed health services, especially antiretroviral drugs. It is essential then that alternative modes of delivery of antiretroviral agents, such as through courier services or parcel services, be considered at this time of the ECQ, and that such cost of services may be charged to the PhilHealth outpatient HIV and AIDS treatment package reimbursement. For the 80% that were given to the treatment hubs, the cost of the courier services are being charged into that reimbursement. These are the strategies adopted in the new normal. There's transient refill across 160 treatment hubs. For example, a patient has been locked down in a certain area. They are advised to go to the nearest health facility to access antiretroviral drugs for refill and other clinical care. Telemedicine platform is also utilized if the patient cannot go to their base facility. Family counseling and treatment adherence are also performed. Learning group sessions and focus group discussions has been done during the pre-pandemic and still during the pandemic. But there is the wearing of masks and face shields, and social distancing or physical distancing is observed. For the courier delivery services, there's a need for an SMS appointment, and then there's the preparation of ARV drugs prior to dispatch, and there's the actual turnover of the commodities to the courier service. Mental health is also being addressed during the time of the pandemic. Stress debriefing is also done, which is a facilitator-led group process conducted after a traumatic event or an individual who is under stress. This might be in a form of counseling also. Several webinars have been conducted with several topics. One is the psychological first aid, which is built on the concept of human resilience. It aims to reduce stress symptoms and assist in a healthy recovery following a traumatic event, a public health emergency such as COVID-19, or even a personal crisis. The key points are the following. Ask the clients about the patient's needs and concerns. Listen to people and help them feel calm. Help people address basic needs and access services, and help people cope with problems. Another webinar was conducted for the HIV and mental health because some of them have depression. Depression is an HIV-related medical condition, and without the HIV medication, it can contribute also to this condition. Counseling for treatment adherence is found to be very important before antiretroviral treatment and during the clinical care and for every visit when they come to the facility or during the telemedicine consult. Lastly, HIV and nutrition is also an important issue because in people with HIV, good nutrition supports overall health and help maintains the immune system because poor absorption leads to excess nutrient loss, and there might be opportunistic infection symptoms such as diarrhea and vomiting. Good nutrition helps heal HIV, maintain a healthy weight, and absorb HIV medication. Food safety and food that boost the immune system were also emphasized. These are the strategies adopted in the new normal in the healthcare facility level. This ends my discussion and thank you for your kind attention.
Thank you, Dr. Cherry. For the third speaker, it will be on HIV and COVID-19 at the community-based organization level. And with us is Mr. Rosadino, Danvic Rosadino. He is the Director of Operations at Love Yourself, an organization that promotes self-worth among MSMs, or men having sex with men, and youth in the Philippines. Love Yourself provides HIV-related services such as HIV awareness, testing, prevention, and treatment, care, and support. He served at the DOH Epidemiology Bureau and worked as an educator before his work with Love Yourself. He finished high school at the Batangas College of Arts and Sciences and earned his Bachelor of Science in Biology at UST and a Diploma in International Health at UP. Everyone, Mr. Danvic Rosadino. Okay, good, Danvic.
Good afternoon, everyone. Good afternoon, good morning, wherever you are in the world. I am tasked to present the response of the community with regards to the situation that we are in right now. How do we ensure that HIV services are still ongoing despite there is a COVID pandemic here in our country? And my presentation would be discussing on our perspective from the community perspective. My outline of my presentation for today would first to have a brief review on what is the proper care that a client needs to have if they wanted to access an HIV-related care and service. Ano yung dapat natatanggap nila na serbisyo? And next is what is that unexpected challenge and what is our response to that unexpected challenge? And of course, all the lessons that we have learned and how to move forward from these lessons. It is very important to note that in the HIV care of Cascade, a person living with HIV has to undergo this cascade in order to receive the proper services that they need to attend so that they will be able to achieve viral suppression or they will become undetectable. If they are undetectable, they will not be able to transmit it to other people. And also, it's very important that if they are undetectable, they will basically be living a normal life, a happy and healthy life. And that starts with diagnosis. If they are been diagnosed with HIV, if they have been linked to care, and if they are already receiving medical care. But in our organization in Love Yourself, we are already employing a new approach, and this is what we call the status neutral approach. This approach redefines the HIV cascade of care, and this now includes HIV negative individuals. It is from the premise that not only those who are HIV positive individuals need to attend care. Also, of course, it's equally important that those individuals who are HIV negative also receive care for them to prevent future HIV infection. This approach employs the strategy of using a combination prevention approach, meaning ensuring that the prevention approach that is important to them, that is more adaptable to their lifestyle. And also employing a client-centered care approach, meaning our clients receives the best care that they deserve, which is already adaptable to their lifestyle. And the goal of this approach is to have a negligible risk of either transmitting or acquiring HIV infection. And again, as I mentioned, this approach employs that regardless of your HIV status, one should receive the healthcare that they need. And of course, aside from receiving HIV care, it's also important to consider the access to HIV care service is also affected by intersectionality, meaning other issues that are arising depending on each and every client, regardless of whether they are part of a key population. And these intersectionalities affects their service, their access to HIV-related service. And what we have seen in this COVID-19 pandemic, it was an unexpected challenge for us. Way back 2019, as mentioned by Dr. Rafi Deray earlier, we are already experiencing 35 cases per day before the COVID-19 pandemic. And as you can see, the number of Filipinos diagnosed per day actually reduced from 35 to 33 as what we are experiencing now. But what we always say is that data is always a double-edged sword. We may see here that the cases have been decreased, but the actual reason why the numbers have decreased is because there's a less number of people who are accessing HIV testing services, of course, considering their concerns that they want to be protected against COVID-19. And that also shows that the limited mobility that it shows that there is also a limited access for treatment, especially for those who are living with HIV. As of March 2020, as you can see in the graph that is shown in the slides, there is a reduction of those people who are initiating on ART. And right now, as of April 2021, out of 86,771 Filipinos who are diagnosed with HIV, around 57.85% of them are on treatment. And this poses a challenge. Of course, if they are not on treatment, there is a possibility that they can transmit HIV to other people. And because of that, we need to increase the number of people who are initiating treatment. But aside from accessing HIV-related service in itself, there are also other challenges that needs to be considered. Of course, there are concerns with stigma, discrimination, and unnecessary disclosure, especially for clients who will be refilling or are not comfortable in refilling their medication to their nearest treatment hubs. Also, there are concerns, of course, of financial security and mental health concerns that are highlighted during this time. For our friends who are transgender women, of course, access to trans health services are also affected during this time. And for those people who are injecting drugs, their access to HIV-related services have been worsened from a baseline of an already poor access to HIV-related service. And because of that, we, the community, have started our own response in collaboration with the government and other stakeholders so that we will be able to augment with the response so that we will be able to help our community. And that is our response, our community helping other communities. So some community-based organizations have made innovations in prevention service delivery by delivering online outreach, information dissemination campaigns, especially promoting these services online, harnessing the power of social media so that we will be able to transmit the key messages that our clients need to know so that they will be able to protect themselves against HIV, or if they have HIV, for them to be adherent to their medication. And of course, fundraising activities for other community-based organizations so that they will be able to continue their services. And of course, recruitment of volunteers so that they will be able to help with the response. Also, there are, for those community-based organizations who have their own community centers, a scheduling or an appointment to HIV testing at community centers replaced to ensure physical distancing at their centers. Also, other community-based organizations continued to provide innovative access to HIV testing services, which includes community-based screening and other assisted testing approaches. And for us in Love Yourself, we introduced the concept of an unassisted HIV self-testing in the Philippines, which we call the self-care program. This is the first unassisted HIV self-testing service where we will be able to assist our clients in knowing their status, and if they are reactive to their self-testing kit, they need to be linked to a testing facility so that they will be able to access confirmatory testing and eventual linkage to treatment. Also, for our clients who are in need of PrEP or pre-exposure prophylaxis and their antiretroviral medications, delivery modes were employed by different community-based organizations. Of course, also in line with the department memorandum that was released by Department of Health, satellite pickup points were also set up, and some community centers were also designated as temporary pickup points, especially for those large treatment hubs who were designated to be COVID-19 facilities. So this is an augmentation of services so that we ensure that the continuum of care is ensured at tuloy-tuloy pa rin siya. Of course, for other community-based organizations, also with community centers and primary HIV care facilities, we were also able to set up telemedicine services for our clients so that the need for our clients to go to a facility just to access a consultation is reduced. And also for clients who are needing linkage to care, we also establish an ambulatory service so that we will be able to link our clients to care, in particular for those people who became reactive to their HIV self-testing kits. Also, what we did is also we provided services that caters to people with mild depression and anxiety that has been brought upon by this pandemic. And we were able to do these peer sessions via virtual sessions, which we call Flourish Circle in Love Yourself. And of course, we also provided appropriate referrals for clients who are in need of mental health services if they need consultations from psychologists or psychiatrists. And also for us in Love Yourself, in partnership with the Mandaluyong Local Government Unit, we were able to organize a COVID-19 vaccination drive for our clients who are under A1 to A3 categories. As released by the IATF, people who are living with HIV are under the A3 category. And we were able to set this up so that we will be able to offer an avenue for clients who don't want to disclose their HIV status in their respective local government units if they want on their own vaccination drives. And what we were able to offer in this vaccination drive is that there is a seamless consultation since our clients already enrolled in our facilities, and provision of guidance for those clients who are returning to care if in case they are already lost to follow-up and they appeared for this vaccination drive. So what we have learned as a community is that what we know is that the COVID-19 crisis was exacerbated by it has shown the vulnerabilities of our fragile health system, and it has also brought upon and greatly affected our people living with HIV and other key populations in accessing HIV-related services. And what we have seen also is that we can harness the power of online technology so that we will be able to provide continued information and awareness, and also for us to continue to provide continuous offering of our HIV-related services, whether it's that for prevention or for treatment care and support. And what we have seen also during this time is that community-based organizations and other civil society organizations can augment public health sector efforts in the continuation of HIV-related services. So coming from those lessons learned, how can we move forward from these lessons? First and foremost, the COVID-19 pandemic is not over yet. So we need to continue these interventions and continually improve them so that we ensure a client-centered approach for all of our clients. And again, in order to create access to HIV-related services, we should continue to provide client-centered and differentiated services for the community that is mostly adaptable to their lifestyle. And of course, to understand affected communities is essential and is central so that we will be able to develop approaches which addresses people's risk, their perception of risk, and their need for a seamless and equitable access to quality service. And it's very important for other stakeholders to involve the communities in their HIV response, because we will be able to share our insights, to share improvements, and to share our lessons so that we will be able to replicate this to the community. Because as we say, we know the market because we are the market. With that, I end my presentation and thank you very much for listening.
Okay. Thank you, Danik. Now we'll go to the open forum. Can we ask the panelists to open their video if it's possible? Our three speakers. There's several questions. Like for example, regarding the courier services fee. I think there's some patients living with HIV are being charged for this one, and they said under the PhilHealth guidelines, they don't have to pay for this one. How do you address this? Any advice for this one, Dr. Terry or Rafi?
Oh, okay na.
Yes, ma'am. We can hear you.
Okay. Regarding the OHAT PhilHealth package, they are required to if they are PhilHealth members, they are required to submit some documents, and they are being evaluated if they can access the OHAT services. If they are found to be approved for the OHAT service, then the delivery or the courier fee is waived, care of the OHAT package. If not, they have to pay on their own. So they have to be convinced to enroll to PhilHealth so that they can access the OHAT services that is being offered.
Okay, thank you, Terry.
Okay,
next question is the young teens aged 14 to 25 contributed to the increase in the numbers of patients living with HIV. It's an alarming data. How do we do contact tracing in this population so that we can decrease the figures that we are getting? So Rafi and anyone from the group?
Can I respond to that?
Yeah, go Rafi.
Actually, this is actually being addressed right now by the program. So we're currently updating the HIV testing service guidelines, wherein we're now introducing index testing. It's a form of contact tracing, wherein individual with PLHIV, contacts of individual with PLHIV will now be interviewed on this. So it's like contact tracing. So this will now be being included the new testing guidelines that we're developing, and hopefully we will soon implement it together with our implementers.
Okay. Jerry, you want to add something on that aspect? You're muted, Jerry.
Okay. For the young people, we ask the help of the peer support groups and other NGOs that are addressing this population. So when we are in partnership with them, they can help us have the young people come to us for testing, or if they're more comfortable in accessing the other NGOs like the peer support group also, and then the Love Your Health, they are very much open in addressing these issues of young people, because there are people especially the young population, don't really go to the health facilities because they have this wrong sense of notion that if you go there, you are being labeled as such. So I think it's more comfortable for them to be going to the other peer support group and other non-government organizations. Thank you.
Danvik, you want to add something to that with regard to your experience with these young people?
I think it's very important to note that the young key population has different needs. They might not be aware of how they would want on how they would prevent HIV, or they want to treat HIV, because right now in the Philippines, while it's already mandated, it is not widely known na we have a comprehensive sexual education in the Philippines. And there are all other educators who are also understandable that they are not comfortable in sharing these insights. So as part of the community, our response is to promote, create and promote information awareness drives and other campaigns that are first education for them. It's very educational for them. The second one is very entertaining for them because it's madaling gumawa. It's very easy to create campaigns that are very educational, but to keep them engaged, it's a challenge for them. So it has to be entertaining for them. And of course, the last one is it has to be inspiring, meaning there in every campaign that we do, there should be a call to action based on their learning, what they have learned, and how they would apply it to their lifestyle. So that's very important in creating a information drive and a demand generation campaign.
Okay, this is another question. Anyone can answer for this one. Especially it's the government, I think, that is being asked for this one. What is the move of the government regarding trans health in the context of HIV program? Any move or guidance on HRT? And being HIV patients are immunocompromised, are there special care or treatment regimen or being provided for HIV who are affected with COVID virus?
I will partly answer. For the trans health concerns, I think this was included in the current Global Fund program, and I think they're getting a technical assistance from WHO on how they're going to develop this kind of support. So for now, we don't have yet, but there are plans to develop one through the Global Fund project.
Okay. How about in San Lazaro, Dr. Cherry?
Yes, sir. I can respond to the patient who has HIV and at the same time COVID-19. Like what I said a while ago, when a PLHIV comes to us for consultation, we have to screen them if they have signs and symptoms of COVID-19, which can also present as signs and symptoms also of opportunistic infection. So we really need to send them to the triage area for them to be screened for such. Because when they are being swabbed and then they turn out to be negative, then they can come to our area, which is the HIV outpatient. And when we do the consultation, we emphasize the need for them to adhere to the medication. Because it's one of the issues that if they adhere to the medication, the HIV is well maintained, so they have undetectable viral load. So in a way, their immune status is strengthened, so they cannot just succumb to COVID-19 infection.
Okay, this is with regards to vaccination, which is being done at the LGU level. What are the strategies so that they don't have to disclose their status to the LGU? How can this be done?
Can I respond to that? Actually, you love yourself has more experience on this. The Department of Health is supporting this. In fact, we're encouraging our LGUs to to support the vaccination of PLHIVs. And of course, we know concerns about the privacy concerns of our PLHIV, and therefore we're working with our partners, especially our NGOs, on how we can help them support their activities in promoting and helping our PLHIV, how they can access COVID vaccine in the LGUs. So with that, through the Global Fund, we are actually supporting a team of Donvic, the TLY in Mandaluyong, and we are also encouraging them to expand their vaccination campaign in other cities here in the Philippines. So that's what the government is doing as far as the DOH is concerned.
Thank you. And
Okay.
yes, Cherry.
Yes, sir. Because they are prioritized also in the classification of whom to be vaccinated first, like the healthcare workers, and then the next one is the senior citizens, and the E3, they belong to that area, to that classification in which PLHIV and those with other comorbidities can go to the local government units for them to be vaccinated. However, there was a move from the Department of Health that the PLHIVs can go to the treatment hubs for them to be vaccinated. But as of the moment, no vaccines has been deployed yet to our institution. So we're just waiting for the guidance from the Department of Health.
So I think I have time for one more question. Okay. This one is I think you have answered already this one with regards to shortage of HIV ARTs and pre-exposure prophylaxis. And it said we're getting some being supported by WHO, and then is doing the also is part on this one. This one is on self-stigma as a dangerous form of stigma. How do we balance this with the in the context of normalization of HIV? Are we doing something special treatment on how to reduce stigma? Anyone?
Sige po, ako muna. I'll answer to that. With regards to stigma, it is understandable because HIV is a very highly stigmatized disease. We are not, especially in our country where we have our cultural background where we are very conservative, we don't really discuss much about sex. And, that entails that we don't also discuss other issues that are attached to sex, which includes HIV, protecting yourself from other sexually transmitted infections, teenage pregnancy. So these are all connected because we don't really talk much about sex. And that's understandable because this is our culture here in the Philippines. But what we can do is, if we would want to erase stigma overnight, that cannot be easily done. But what we can do in ourselves is to start conversations regarding not about sex, but really more of how you protect yourself from other sexually transmitted infections. How do you ensure that before your first sexual encounter, you are already protected and you know how to take care of yourself? I think it's high time for us to start these conversations among our friends, among our peers, and for us to supplement ourselves with reliable and factual information. Because our tendency, especially for the youth right now, is to explore other means of information. Well, we don't know if they are accurate or not. So I think it's high time for us to start these conversations. And for those who are in need of this information, we link them to not only reliable sources from the government, but other community-based organizations who are already providing this information so that we ensure that our community will be able to receive that information that is factual. And at the same time, we will start from there. Small steps muna before we ensure that we hope that in the future, stigma will be eliminated. But for now, at least for us to start these conversations.
Okay. I think if there's any last message from any one of the speakers before I close this session. It's also running out of time. Ma'am Cherry?
Okay, sir. We know for a fact that counseling is a very important cornerstone in the management. It should start from there because if a patient is HIV positive, more often than not, the family doesn't even know that that person is HIV positive. So when a patient comes to us, we discuss disclosure issues. So if the family can accept the person living with HIV, then it would be easier for him or her to accept the diagnosis. And in fact, if the family can support this person, then other people might not be so resistant and stigmatize the patient. Thank you.
Dr. Rafi?
I would like to emphasize the UU message, which is undetectable, untransmittable. So actually, for me, this is one of the biggest messages that we can send to all our PLHIV patients, relatives and friends, that once a PLHIV patient has suppressed its viral load, meaning say it's already undetectable, so that's the U, the patient can no longer transmit the disease. And therefore, what I can say, what I want to emphasize is, there's life after HIV, as long as you're immediately diagnosed, you are treated, and then you adhere to the recommended treatment, and you become virally suppressed, then you can live a normal life, and you cannot transmit the disease. And therefore, what my message is to everyone is, help us, the Department of Health, and all our partners, to send this message that there's life after PLHIV. Well, I've seen many PLHIV have lived more than 20 years on ART, and they're not transmitting the disease. So I think this is the message that I would like our group, our participants, to send to all the PLHIV patients, to high-risk individuals, and of course the general public, that PLHIV, there's life after PLHIV, and a PLHIV may not transmit the disease once it's been treated and declared virally suppressed.
Okay, I think that's wrap it. Thank you for our speakers, Dan Vic, Dr. Cherry, Dr. Rafi. And with that, we have a lot of questions for everyone, but we don't have time anymore. I think we'll try to find ways on how to address this. Probably the organizers can do something about this one. And for the benefit of everyone, we have 67 participants or watching us right now. And with that, I'd like awarding of the certificate of appreciation for our speakers. For Dr. Rafi Deray. Sorry, I can't read. It's too small for me. Thank you, Dr. Rafi. Ma'am Cherry. Dr. Cherry, and for Dandy. Thank you. And with that, we'd like to tell everyone to watch us for next week on the second session of this series of webinars. And the title will be COVID-19 Narratives and Realities of the PLHIV Community. It will be the same time, Saturday. Okay, with that, we close this webinar and have a good day, have a good evening. And we want your feedback. Please send us your feedback. And this is the link for the feedback.
Wind, show me where to go.